So let's look more into cultural competence. Throughout this PowerPoint, we're going to look at what cultural competence is, what cultural awareness and knowledge requires, the cultural skill, encounter, and desire, some health disparities, and guidelines for nursing interventions. So these are just some cultural related terms. So first, culture. This is the shared beliefs, values, norms, and practices that guide a group's way of thinking, behaving, and interacting. So culture really can influence multiple things, such as an individual's health beliefs, dietary practices, their communication, and the way that they make decisions. Culture is really a dynamic. It'll change over time and it really will differ within groups. As nurses, we must recognize cultural factors to provide really holistic and person-centered care. Next, you have unconscious bias. These are attitudes or stereotypes that affect understanding, actions, and decisions in an unconscious manner. So we are not aware of these attitudes and stereotypes. This often occurs automatically without awareness or intent, and it can influence that nurse-patient interaction and then lead to inequitable care. So us as nurses, we really need to make sure that we are self-aware and we can reflect to help identify and mitigate any of these biases. So, for example, assuming a patient from a certain culture prefers family-centered decision-making without asking. We cannot just assume, we do need to still ask that patient. Implicit bias, that is when we are personally aware of the bias that is presented within ourselves. So we do know that we have that bias. Culturally congruent care, that is care that fits the patient's valued life patterns, beliefs, and meanings. As a nurse, we must understand and respect that patient's culture while meeting their health needs. We can achieve this through an assessment and accommodate those cultural practices the patient may have. There may be times when we need to negotiate, and negotiations will occur between yourself as a nurse and the patient. So, for example, we would want to make sure that we incorporate traditional healing rituals that an individual may have alongside prescribed treatments when safe. So making sure that we are continuing that education. And then you have two different types of worldview. You have emic and etic. So emic is the insiders or natives' perspective, so how members of a culture perceive or interpret their world. And then etic, that is an outsider's perspective. So this is viewing another culture through one's own cultural lens. Then you also have stereotyping or stereotype. That is generalized and often oversimplified belief about a certain group of people. So what is cultural competence? So this is the ability of healthcare providers to understand, respect, and effectively respond to the culture and linguistic needs of a patient, especially from a diverse population. Cultural competence is a continuum and there's really no end point. We as nurses will need to continually learn and adapt regarding different cultures. So what does culture really entail? It entails what people believe, how they live, and what they consider to be important. Culture is not limited by ethnicity or race. It's a very complex mix of traditions, beliefs, and life experiences. So then why is cultural competency important in nursing? It helps promote trust and communication, both of which improves that patient satisfaction, and then it reduces health disparities and ensures equity in care delivery. So in order to be culturally competent, we must identify that there are these 5 components. These 5 components are interrelated, as you can see in the image, in order to be culturally competent. We'll provide more detail on the next few slides. So cultural awareness, that's just being able to recognize your own cultural background, values, and beliefs. And then cultural knowledge, seeking and obtaining information about different cultures. And then cultural skill, that's the ability to collect relevant cultural data and perform culturally based assessments and interventions. And then cultural encounters, that's engaging directly with cross-cultural interactions from diverse backgrounds. And then your cultural desire, that is the want to engage in the process of becoming culturally competent rather than feeling obligated to. So again, a little bit more of a deep dive into those components. So cultural awareness. This is when we need to self-examine our own cultural background, beliefs, values, and biases, and how these influence interactions with individuals from other cultures. So it starts really with us being able to self-reflect, understanding how your own culture shapes your worldview and nursing practice. And it also helps nurses identify any prejudices they may have, stereotypes or assumptions that may affect that patient care. And then you have cultural knowledge. So this is the process of learning about different cultural or ethnic groups. It includes their health-related beliefs, practices, values, and customs. And this is obtained through education, research, and interactions with the diverse populations. Involving understanding communication styles, nutritional practices, family roles, and health beliefs as well. And then we really want to be able to enhance our ability as nurses to anticipate patient needs and provide culturally appropriate care. So for instance, many times in a Hispanic or Latino culture, family plays a central role in healthcare decision, and they have some traditional remedies such as herbal teas, natural treatments that may be utilized alongside their prescribed medication. So just having that in the back of your mind, asking questions, because again, you don't want to just assume or quote unquote stereotype your patients. Next, you have cultural skill. So this is the ability to collect relevant cultural data about a patient's health problem and perform a culturally based assessment and interventions. So this is when we're going to really utilize open-ended, culturally sensitive questions during an exam or during an assessment. So, for example, a nurse caring for a Muslim patient, they may want to schedule medication times around daily prayer. And that's a skill. So you're going to be changing the way you do things to adapt to that individual's culture. And this really shows that building ability to adapt, and that is related to the skill. Cultural encounters. This is engaging with different cultures and different cultural beliefs and ethnic backgrounds, allowing the nurse to refine or challenge pre-existing beliefs. This helps us reduce stereotyping and build that natural or that cultural understanding. And then cultural desire. So this is the motivation or the quote unquote want to engage in becoming culturally aware, knowledgeable, and skillful. So not because you have to or you are obligated, but rather because you want to. So that's the desire component. Cultural desire aligns with the LEARN model. So LEARN model is a framework for cross-cultural communication that will help us as nurses translate cultural desires into action. So each letter of LEARN means something different. So L means listen. So we want to listen with empathy and understanding when we're talking with our patient and their perception of their problem. E, we want to explain. So explain our perception of the problem and then your professional viewpoint, making sure that we clarify medical concepts in very simple, realistic terms. So we want to explain things, but utilize simplistic terms and not medical jargon. A means acknowledge. So we want to acknowledge any similarities or differences between perspectives. So recognizing and validating the patient's belief without any judgment, and that's going to help us build trust and show openness with our patient. This is really the hallmark of true cultural desire, is that acknowledge of the A in LEARN. R is recommend. So we want to recommend a treatment plan that incorporates both perspectives when possible. So the medical perspective and the cultural accepted perspective as well. You can continue, for example, with the the Hispanic and Latino culture and background. So we may know from talking with them that they do like to do herbal teas. So what we can do as a recommendation to incorporate both medical and culturally acceptable perspectives, you can always say, okay, you can continue your herbal tea, but we'll have to monitor your glucose levels closely for maybe a third line. And so the last letter in learn is negotiate and agree on a plan that is acceptable for both the patient and the provider. So we need to make sure that we're being flexible. We still have respect and desire for both the patient and the provider. So next, what are health disparities? These are preventable differences in the burden of disease, injury, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So these differences are typically closely linked to social, economic, and environmental disadvantages. Health disparities reflect inequalities, not just differences, and it is influenced by the social determinants of health, which we'll talk about in the next slide. So some examples of health disparities. So populations that commonly will face these disparities include any racial, ethnic minorities, low socioeconomic status, those living in a rural area, and then individuals with disabilities and those of the LGBTQA plus community. And so these are just a list of some of the different examples. So then with the health disparities, you have the social determinants of health, SDOH. So these are conditions in which people are born, grow, live, work, or age that affect a really wide range of health outcomes and their quality of life. These factors are shaped by the distribution of money, power, and resources related at global, national, and even local levels. Simply, these are non-medical factors that are going to influence somebody's health. So there really are 5 key domains of the social determinants of health. The first one is your economic stability. So this refers to income, employment, and the ability to afford necessity. So some things that may play a factor with that economic stability is if somebody is living in poverty, they don't have any job security, they have a tremendous amount of debt, they don't have a stable housing, or they are having that food insecurity. Then you have education access and quality. So what is that access to quality early childhood education and even at the high school and higher ed levels? So this really correlates back to literacy levels, health education, and language barriers that may occur with certain populations. Then you have neighborhood and built environment. So that's the physical surrounding where that individual lives and work. So is there safe housing? Is there transportation? Is there any pollution going on? What about their access to grocery stores, green spaces? And what about their neighborhood crime rates? Then you have social and community context. So this is the relationship and interactions that provide support and shape well-being. So are they experiencing any discrimination? Are there social support networks in place? Do they have a support system? What's the community engagement look like? And then even, incarcerated individuals can land underneath this category. And then you have healthcare access and quality. So what's the individual's ability to access and receive quality, culturally competent healthcare services? So for instance, do they have health insurance? Is there a provider availability close by? Health literacy will also play a part in the healthcare access and quality. And then what is the cultural competence of the providers? So these are just some guidelines for nursing interventions. So we want to always examine our own cultural influences and look at those biases. We want to be accepting, objective, and non-judgmental about an individual's beliefs. We want to learn general observations about different cultures, so being knowledgeable. We want to incorporate clients' cultural background into their healthcare. We want to accommodate any cultural dietary needs or practices when possible. And then we really want to teach each individual as an individual. So we want to teach them based off what their maybe cultural background is, and make sure that it's tailored to them and something that they will want to proceed to do even outside of the hospital. So here is an NCLEX practice question. So this is the first question. A nurse is attending a continuing education session on cultural competency. Which of the following are components of cultural competence according to this model? So we already talked about these. So select all that apply. You can pause it here while you guys choose your answer, and then the answer will be on the next slide. So the answer are, there are those 5 components of cultural competency. So we want to be culturally aware, have that skill, cultural encounters, we want to have the knowledge and the desire. All right, next question. A nurse is caring for a client with a low-income neighborhood or from a low-income neighborhood who presents with chest pain. Without assessing thoroughly, the nurse assumes the client is exaggerating to obtain pain medications. What does this scenario best reflect? Again, you can pause this, and the next slide will be the answer. So the answer is implicit bias. So what is that difference between implicit and unconscious bias? So unconscious, that is where you don't have the awareness or intent. It just kind of occurs automatically. So that's why it's important for us to be self-aware. Whereas implicit bias is you are personally aware of the bias that is present within yourself. Question number 3. A nurse is asking clients risk for poor health outcomes based on social determinants of health. Which of the following are considered the SDOH? Select all that apply. Again, you can pause this while you choose your answers. And the answer is access to nutritious food, employment status, health literacy, housing stability, and the quality of their local schools. Medication side effects and genetic history or genetic family history are not part of the social determinants of health. If you do have any questions, please feel free to reach out to me regarding the cultural competence.